Our responsibility does not begin and end with writing guidelines, but in implementing those guidelines, in training people how to do things and how to respond to their findings. If you know that we are dealing with a monochorionic twin pregnancy, whether there's a chance of 1 in 6 really, that something will go wrong, the most serious, the most risky type of pregnancy of all, and you don't look at them in great care each time you see them, thinking that things may be wrong. You must not become paranoid. You must remain positive in encouraging the women that things are well. But before you tell them things are well, you better make damn sure to exclude things that are not well. But if I take the high blood pressure of pregnancy, 2 or 3 in 100, 1 in 30, 1 in 50. If I take very severe premature birth, one of the main causes of death and handicap in obstetrics, 2 in 100, 1 in 50 again. If I take monochorionic twin pregnancies, and there's a chance of 1 in 6 that things will go wrong, every time you see a woman with a monochorionic twin pregnancy, you say, my God, am I going to do a scan now and find something seriously wrong? If you start with that frame of mind, you make damn sure that before you lift the transducer off the abdomen of somebody, you have checked that the babies are equally growing, that the fluid around them is similar, the blood flows in the umbilical artery, in the ductus, and the brain are similar and normal, and then you can tell them things are well. Let me see you again in a week or 2. But unless you have done those 3 things, you cannot abandon the patient to the luck of the gods.
Just gold, absolutely gold, and just 100% exactly how I feel about it. It is unacceptable not to be doing the very best, and it's not happening. And I wish that it is. And I've come to the point where last week I shared the videos from your website on how monochorionic and dichorionic twin pregnancies are diagnosed and what to look for, because I'm sending the message to women and families to become their experts in their own pregnancy, so that they can, when they get scanned, they can look for these things and say, oh, can you show me where the lambda sign is? Can you show me where the T sign is? But they shouldn't have to do that. But that's where, unfortunately, we are.
Dan, Sarah, that's exactly what I also did over the decades. And that's why in my website, I have the same educational material for doctors and sonographers and the patients themselves. There's only one target group, anybody that is interested. I try to make things equally simple for all 3 groups of professionals: the woman, who is the most important, that is pregnant, and the people that are taking care of them, whether they're sonographers or doctors. Quite often, the women themselves, it's sad, but they know more than the people that are looking after them. I realized that in the 90s, early 90s, with the nuchal translucency. That is why I campaigned with women's groups, because the women themselves that were pregnant, they were more knowledgeable than their professionals, and they were going to the hospitals and they were demanding things to be done. And the sonographers and the doctors did not know. The women knew more.